So hello everyone, my name is Al-Hashimi. I'm a recent graduate doctor this year, summer 2020, and today I'll be talking about orthopedic fractures. This is the second part of a small mini web series by S-Docs, of which there are 3 parts. So if you've missed the first part, I'd recommend you go back before starting this one. If you would like to see some of my colleagues' lectures they are producing, do click on any of the other videos on this channel. Please do be sure to make sure that you check out part 1 and part 3 of this video, which you can find in the description of this video below. Please like and subscribe to the Medics.Academy YouTube channel. And if you are a medical student, feel free to sign up for the free S-Docs program, which you can do so from the link in the description of the video. Right, so part 2 of my mini web series will be focusing at specific types of eponymous fractures that are important to know at an undergraduate level for your exams. So part 2, types of fractures. We're going to start off with clavicular fractures. So generally what I'd do is I'd start with focusing on the upper limb and start moving down towards the lower limb. However, there are some odd ones out, such as clavicular fractures. So clavicular fractures, as the name obviously says, it's a fracture of the clavicle, and it's more commonly seen in children. The most common types are mid-shaft clavicular fractures. And the way that we classify them is shown below in this table here. So grade 1 is the middle shaft, which is the middle 1/3, and this is the majority of the cases, or 69% of the cases. The second most common is the distal 1/3 shaft fractures, in which is closer towards the acromioclavicular joint, and the proximal 1/3, which is attached at the sternum, rarely has any fractures, only 3% of fractures. This, as mentioned, it predominantly affects children and is typically seen in adolescents and teenagers. So the general causes of this are direct falls on the shoulder or direct trauma to the shoulder. You can imagine someone playing a contact sport such as rugby is prone to things such as a clavicular fracture. Foosh, which is a fall on an outstretched hand, is also a cause for clavicular fractures. However, makes up less than 10%. You'll tend to find that throughout this lecture that foosh will make up the majority of the causes for different fractures along the way. So we discussed the clinical features of fractures generally in my last video, and we will be repeating them. The things that I've noted in purple are the most important things that I'd recommend that you take away from this video. It's generally quite obvious that you would expect the clavicle to be painful with some erythematous swelling at the site of the fracture. There may also be some displacement and misalignment of the 2 fragments of the clavicle. Tenting of the skin above the fracture. So generally here, what you see here is a mid-shaft fracture, which is a grade 1. You'll see that there will be tenting, it's likely that there will be tenting of the skin as the proximal portion is angulated upwards, pressing along the skin just above the clavicle, and therefore it forms a tent. There's also elevation of the acromioclavicular joint, as shown here, due to tearing of the acromioclavicular ligaments surrounding the clavicle. And then you will also see that there will be shortening of the clavicle. The reason why there is shortening is because you tend to see that the pectoralis muscle starts to pull on the scapulohumeral joint, which is found obviously at the back of your shoulder and the top of your humerus. And generally what it causes is medial displacement of the lateral clavicular fragment, bringing it more medially, and therefore as a result it will seem as if the clavicle is actually shorter than usual. The management that we generally tend to recommend for clavicular fractures is either conservative or surgical. Conservative would involve the use of a shoulder sling, and it's probably more recommended for cases in which there is not that much displacement. Surgical, excessively shortened or displaced, we do tension banding or use a clavicular plate. Humeral fractures. Humeral fractures are fractures of the humerus. They are classified as proximal, diaphyseal, and distal. The most common in elderly patients are the proximal. The diaphyseal or the shaft fractures are themselves classified into 1/3s. So a proximal 1/3, a middle 1/3, and a distal 1/3. The most important one to remember for a shaft fracture is the distal 1/3. The reason for this is because it is known as a Holstein-Lewis fracture. A Holstein-Lewis fracture is the fracture of the distal 1/3 or distal third of the shaft. And generally, the reason why it's important is because that the radial nerve tends to wrap around the humerus following the radial groove, closer towards the distal portion of the shaft. Therefore, a fracture there also causes potential palsy by damaging the nearby radial nerve. It can also be classified according to comminution. Distal fractures are also quite important. You can have a fracture of the epicondyles of the distal portions of the humerus. However, more importantly to remember is a supracondylar fracture, which is the most common pediatric elbow fracture. Here is a picture of a supracondylar fracture. So generally what we tend to see is that these cases generally tend to affect elderly patients with osteoporosis. It's more common in females. The etiology is direct or indirect trauma, and the clinical features are there would be painful erythematous swelling at the site, as mentioned prior, displacement of the bone fragments, and bone fragments can also be noticed if this is an open fracture. There is a potential risk of neurovascular compromise, which always needs to be remembered. In the Holstein-Lewis fracture, as mentioned earlier, there is a risk of radial nerve injury. In a supracondylar fracture or a distal fracture, there is a risk of the brachial artery being perforated, especially as seen, and so the brachial artery would run generally around here. And if there was an injury there, it is likely that there would be a perforation of this artery. This can be quite worrying. So the investigations of almost every fracture is always an X-ray. The proximal and shaft fractures have normal signs, whereas a distal supracondylar fracture generally tends to follow something called a Sale sign, which is shown here, an anterior fat pad sign and a posterior fat pad sign. If you zoom in on the picture shown here, what you'll see is that there is black opacities kind of in front of and behind the elbow. These represent the anterior fat pad and the posterior fat pad. Management, conservative therapy, non-displaced closed fractures. And then there is also surgical intervention in open and displaced, and also in cases of neurovascular compromise, such as the supracondylar or the Holstein-Lewis fracture. For that, we tend to use IM nails or plating. So now we will take a look at distal radial fractures. These are some of the most important fractures that I'd recommend learning for your exams. There are 4 main types that we recommend: Colle's fracture, Smith's fracture, which is a reverse Colle's fracture, a Galeazzi fracture, which is a fracture of the distal radius with subsequent distal radial ulnar joint dislocation, and a Barton's fracture, which is similar to a Colle's fracture. However, it subdivided itself into 2 types, and it's an interarticular fracture of the distal radius. So Colle's fracture is shown here on the right. It's also known as a dinner fork deformity. It's usually the product of falling onto an outstretched hand. So Fuchs generally is responsible for a Colle's fracture. What we see is that the fracture results in hyperextension of the hand at the wrist. The fragment is usually radially and dorsally displaced. If you take a look at the hand, this is the palmar aspect and this is the dorsal aspect. So there will be dorsal displacement of the bone, and it would usually be radially displaced, closer towards the radial bone itself. Now, so the clinical features and why this is important is that there would be painfully erythematous, as with all fractures, impaired range of motion at the wrist. This is to be expected, especially because there is damage or injury close towards the distal, at the distal radius, close to the actual radiocarpal joint. And you will see that the fragment is dorsally and radially displaced with some dorsal angulation too. An X-ray would generally tend to show everything that was just mentioned earlier. So the management, closed reduction is an option in these patients as it isn't always necessary for surgical manipulation of the bone fragment. If we have 2 simple bone fragments which fit right back into place, closed reduction can be, we can opt for closed reduction. However, surgical intervention is usually performed when the fracture is usually massively displaced. For that, we tend to involve the use of Kircher wires, also known as K wires, which are inserted percutaneously in order to achieve fixation. Here is a picture of a dinner fork. You can see the resemblance between the dinner fork here and the Colle's fracture. The Smith's fracture. This is also known as a reverse Colle's fracture. This is also a distal radial fracture, and however, the fragment this time is usually radially and ventrally displaced. Ventral also means it's displaced towards the palmar aspect. This fracture is also referred to as a garden spade deformity. It is the product of a Fuchs in which we fall onto our outstretched hand backwards. It's important to remember backwards. Clinical features is that it's painful and erythematous, loss of motion, especially at the radiocarpal joint, also known as the wrist, and radially and ventrally displaced, plus volar angulation. or palmate angulation to give the garden spade deformity. The investigation would be an X-ray, and the management would be closed reduction. Surgical manipulation isn't always necessary. Surgical intervention, we can also use percutaneous Kershaw wires in this case as well. This is usually recommended when articular involvement at the wrist occurs. Galeazzi fracture. So a Galeazzi fracture may be one of the more interesting types of fractures. A Galeazzi fracture, again, is also to a distal radial fracture, and it's the radial shaft fracture. However, it also results in a subsequent distal radio-ulnar joint dislocation. So it's important to remember that there are two radio-ulnar joints. There is a proximal radio-ulnar joint and a distal radio-ulnar joint. The distal radio-ulnar joint is usually interrupted in a Galeazzi fracture. The proximal radio-ulnar joint is usually disrupted in a Monteggia fracture. We'll come back to this soon shortly. So Galeazzi fractures tend to affect children more commonly. It again is also the product of a fouche. However, there is a rotational force which is generally superimposed. It is likely that you may potentially see a spiral-based fracture as a result of this. So there are clinical features: painful erythematous swelling at the distal radial site, impaired range of motion of the distal radius and the wrist joint, and there is also an anterior interosseous nerve palsy. So what is the anterior interosseous nerve? The anterior interosseous nerve is a purely motor branch of the median nerve, and damage to this nerve results in motor paralysis of muscles located within the flexor compartment, and thus you are unable to make an OK sign with their thumb and finger. If you take a look at the picture on the top left, you'll notice that this is the normal, showing a normal OK sign, and this is an anterior interosseous nerve palsy. It's like mentioned, it's responsible for innervation of muscles within the flexor compartment, particularly the flexor pollicis longus, pronator quadratus, and flexor digitorum profundus. The flexor pollicis longus is located directly below the flexor carpi radialis, and below that would be the pronator quadratus. That's just a tip that you might want to remember for your spotter exams. So the investigation would be an X-ray again, and it would show, as mentioned, a distal radial shaft fracture with radio-ulnar joint dislocation or disruption. And management, since there is not much place for conservative management, surgeons would have to opt for surgical intervention because it is complicated and there is also intra-articular involvement seen. So therefore, we would tend to opt for an ORIF approach, known as an open reduction internal fixation, using K-wires and plating. Here is a picture of the arm. Here also we can take a look and we are also able to see that this is the median nerve coming from the brachial plexus. And here is the anterior interosseous nerve, which is a branch. This will continue downwards until it innervates the three muscles that were mentioned earlier. Those muscles, just to recap, are the flexor pollicis longus and the pronator quadratus, which are found directly below the FCR, the flexor carpi radialis, and also the flexor digitorum profundus. A Barton's fracture. A Barton's fracture may appear slightly similar to a Colle's fracture and Smith's fracture and might actually be slightly confusing as well. However, it is a distal intra-articular fracture involving the radiocarpal joint. So it is at the wrist. It leads to radiocarpal dislocation between the radius and the carpal bones of the wrist. There are two types. There is a dorsal type and there is a palmar or a volar type. The volar type involves volar displacement of the intra-articular distal radius. And then a dorsal Barton fracture is dorsal displacement of the intra-articular distal radius. So you can see it here in this picture. You can see that this is a dorsal fracture. It's similar to a Colle's fracture. However, if you took a look very closely, a Colle's fracture is a fracture through more so the bone with no intra-articular involvement, whereas a Barton fracture has some intra-articular involvement itself. The same could be said between a Smith and a palmar or a reverse Barton fracture. Again, this is usually caused by a fouche falling onto an outstretched hand, extended elbow with a pronated arm. Clinical features: painful erythematous swelling at the distal radial site and loss of range of motion at the wrist. The investigations again would be an X-ray, which would show you an intra-articular fracture, which is unlikely seen to be in a Colle's or a Smith fracture. The management, this is very difficult that we'd be able to do conservative management. Usually we have to opt for surgical because it's hard to carry out surgical fixation with the radiocarpal dislocation. Therefore, ORIF is what we tend to opt for. A Hutchinson's fracture or a Chauffer's fracture. So it's an intra-articular fracture of the radial styloid. It's also known as a Chauffeur's fracture. The etiology is due to a fouche once again. And then you have repeated forces. These are continuous forces which cause compression of the scaphoid against the radial styloid process. The radial styloid process and the scaphoid are adjacent to one another. Therefore, if you have some form of forces repeatedly pressing against it, it's likely that a fragile fragment like the radial styloid process would become dislodged itself. Clinical features: painful erythematous at the site of fracture and wrist pain. So you would obviously have pain at the wrist. Displacement is rarely seen. That's because the radial styloid is only a small fragment, and therefore it's unlikely that we'll see much displacement at all. The investigations, we would have an X-ray again. And the management, we would tend to go for either conservative, because there isn't that much displacement, as mentioned prior. So therefore we could go for a Colle's type plaster, or surgical. If there is massive displacement, only cases of extreme displacement, then we would opt for ORIF. Ulnar fractures. This too is also an interesting fracture, similar to a Galeazzi fracture. And what I'd recommend is that you learn the differentiation between the two, as there are some similarities in terms of the complications that you may want to remember just for exams. So Monteggia's fracture is the most important one to remember. A Monteggia fracture is a proximal 1/3 of the ulnar fracture with subsequent dislocation of the proximal radial ulnar joint. This is more common in children. So this is brought about again by a fouche. What we have is similar clinical features as with all fractures, such as inability to move up the elbow and painful erythematous swelling. The most important thing to take away from this would be a posterior interosseous nerve palsy. Please note that in the previous fracture, which was the Barton's, the Galeazzi's fracture, sorry, it was an anterior interosseous nerve palsy, whereas with the Monteggia's fracture, it is a posterior interosseous nerve palsy. This is an important point to remember. The posterior interosseous nerve is a nerve that is a branch of the radial nerve, which wraps around the posterior end and innervates usually the extensor compartments and also the triceps and posterior parts of the arm. It is a motor nerve, and it results in a motor paralysis of the muscles located within the extensor compartment. Thus, patients generally tend to struggle with extension of their thumb and their fingers at the MCP joints. Metacarpophalangeal joints are also known as the knuckles. I would recommend that you remember this. You can see here that this is the radial nerve. The radial nerve tends to pass through the arcade of Frost. The arcade of Frost is brought about by passing underneath the thickened heads of the supinator muscle within the extensor compartment. As mentioned, it is a motor nerve and it's responsible for motor innervation. Therefore, we usually results in paralysis of the muscles within the extensor compartment, and subsequently we're not able to move our fingers or our thumb. So the management. We would use closed reduction and casting in children, and in adults we tend to opt for ORIF. This is the same in cases where the fractures are complex, such as there is large amounts of displacement, or when there is also situations such as neurovascular compromise. Carpal fractures. These are the most important one to take away from today would be a scaphoid fracture, and that's the one that I'm going to be teaching you. So, a scaphoid fracture. A scaphoid fracture is actually a fracture of the scaphoid bone, which is located within the wrist. It is one of the carpal bones. It is also important that here is a small recap of the bones within the wrist. So, the scaphoid, the lunate, the triquetrum, the pisiform, the trapezium, the trapezoid, the capitate, and the hamate. You can remember this with the interesting saying that medics tend to usually enjoy using. Some lovers try positions they truly can't handle. Little bit crude, but can be very useful to remember things like this in an exam. Here is the scaphoid. Most commonly located, the fractures of the scaphoid bone usually occur in the middle 1/3 of the scaphoid bone. It's more common in males, generally tend to see in early 20s, and it's usually noticed in patients who do contact sports. It can also be a product of a fouche injury once again, where the wrist is hyperextended. This is flexion, and this is extension. Hyperextension would be when there is excessive extension past the point in which it would be a little bit more worrying. It's more likely to present on Mondays and less so on the weekends. It's believed the reason for this is when patients are out consuming alcohol or a little bit more intoxicated, have a little bit of an injury over the weekend, and more likely to come in on a Monday. So the clinical features of this. Pain when pressing on the anatomical snuff box plus the scaphoid tubercle. The anatomical snuff box is a structure which is located close to the radial artery and adjacent to the scaphoid. It is the product of three tendons: the extensor pollicis longus, the abductor pollicis brevis, the abductor pollicis longus, the extensor pollicis brevis, and the extensor pollicis longus. I would recommend that you remember this. There is also a risk of joint effusion. This is more likely to be seen in hyperacute settings, where it's less likely to be seen in hyperacute settings, whereby it's less than 4 hours old since the fracture, or in cases whereby we have left the fracture for a delayed period of time, which is greater than 4 days. That we generally tend to find that is painful pinching, grasping, and there's also decreased grip strength. If we also compress the thumb, you'll tend to find that there is pain at the same place mentioned earlier. There is limited decrease in movement unless displaced. The investigations. The first line, as usual, is in an X-ray. As mentioned prior, we tend to opt to use AP and lateral views of the wrist on the X-ray. 25% of these fractures cannot actually be visualized on X-ray, so therefore we must repeat them within 2 weeks when a scaphoid is diagnosed or when X-ray is inconclusive. Second line that we can opt for is CT. However, MRI is usually the definitive investigation, and therefore we may opt to use this second line as opposed to CT. The CT, however, is better than X-ray, as used for preoperative planning and also determines the extent of union during follow-up. Management, conservative or surgical. Management generally conservative management is if there is a non-displaced fracture, which is less than 1 millimeter, and we use a speaker cast for 4 to 6 weeks. Surgery is usually opted for if there is neurovascular compromise or extensive displacement. Screw placement is the mainstay of treatment. If you take a look at the photo here, what you can see is a screw that has been passed through the scaphoid along the fracture line and therefore is used to stabilize the bone. That concludes part 2 of my lectures on orthopedic fractures. Stay tuned for part 3 or follow the link in the description below so that you're able to continue watching part 3. Thank you very much.